Tell me somewhat about the training experience, because that's why you're here in the United States, is training physicians in this procedure. And you mentioned before that experience with ultrasound and fine needle aspirations was important. So what's involved with a physician learning how to do laser ablation?
You have to consider that differently from radio frequency thermal ablation, where the operator needs to treat with the moving shot technique the nodule, obtaining the fusion of several small units of necrosis that we produce with the device that is linked to the RFA generator. So you move the needle inside to completely cover all the entire volume of the nodule, applying all these shots of energy. But you need, in your mind, to create this three-dimensional compartmentalization of the nodule. It's not a very easy way to teach to a colleague how to do this. It can be natural for you if you are a skilled operator, in the sense that you are an interventional radiologist, or maybe for a surgeon, but it's not so easy to learn for doctors that are very skilled in their professional activity, but not in this interventional procedure. The intuition of the software that plans everything, and of the device that is done in a very easy way to allow the doctor to introduce the needle that you can see in the monitor under the ultrasound guidance, and not that is introduced with a freehand technique. So you can plan everything. By this way, the endocrinologist or the medical practitioner that has a great experience in doing fine needle aspiration biopsies, that means that you, under ultrasonographic guidance, the device to guide your introduction, you already are able to introduce the needle using this technique. With the laser, with the software, and with this application, you have the possibility to do the same thing, because you plan everything. You put the probe with the device housed in the probe, and then you see what you do like a fine needle aspiration biopsy. So it's very easy to teach, but it's very easy to learn, because nothing is led to the imagination of the doctor.
I'm glad you mentioned the device that's attached. So you were describing this right here. Tell me a little bit more about what that is.
You see, we are two operators, because one handles the probe and the other insert the needle guide into the device. The probe has a bracket that is attached on. This bracket houses this device with the hole inside. And according to what we have planned with the software before, we decide to enter the needle guide and then the fiber in the line that better fits to obtain the necrosis that we plan to perform, to reach. See the needle guide with this green cap that are inserted through this guide in the nodule. In this case, we use two needle guides because the nodule, as you can see, in the neck is very, very large, and apply the technique of two needle contemporary with a pullback. So at the end of the first session, in order to achieve a larger volume of necrosis, we retracted, in these cases, the two needles of 1.5 centimeter, and we obtain a larger volume of necrosis.
Is this the ultrasound white?
The probe, yeah.
Right
the
okay.
White one is the probe. Then we have a bracket that is mounted on the probe, and and the other is the device with the holes where we introduce. So we have a package of the devices that we can use, that we can change with different angles, because it's very important to adapt the procedure to the position of the nodule. If we have a very superficial nodule, we can use a device with a smaller angle. So the introduction of the needle is more transversal, more horizontally. When we use this procedure for very deep nodule, we use a very deep angle to introduce the needle in a very deep way.
These are not being introduced via the isthmus like with RFA?
No, this is not possible with RFA, because with RFA, you put the probe on the neck, you introduce with a transsystemic approach. It is quite different from this approach.
Mhm.
Transsystemic approach, it means from the middle line to
Mhm.
the external aspect of the neck. In
Mhm.
this case, we introduced the needle along the major axis
Okay.
of the lobe in order to treat the deeper part before, and then retracting the needle, the cranial part of the nodule. With this technique, we insert in the nodule, we see everything during the procedure that we have already planned before.
Mhm.
Nothing is left to the imagination of the operator.
Excellent.
In this case, technology helps us very much.